Hello, everyone. Thank you for listening. My name's Lavanya.
Hi, I'm Baishali.
We are both doctors working in Belfast currently. Our audit focuses on reducing polypharmacy in geriatric patients, with a particular focus on deprescribing. So polypharmacy is typically defined as the use of five or more medications, and it's becoming increasingly common in the geriatric population due to the higher occurrence of chronic conditions. Whilst it's often necessary for disease management, it's associated with high risk of first drug reactions, medication errors, and avoidable hospitalizations. For safe and effective pharmacotherapy, the medications should be reviewed for both over and under treatment and adjusted within the context of an individual patient's care goals, their current level of functioning, their life expectancy values and preferences. And timely medication review on admission ideally is essential to ensure safe and appropriate prescribing in this vulnerable group. Appropriateness of polypharmacy among geriatric inpatients with a focus on identifying potential inappropriate medications and looking for opportunities to prescribe in accordance with current clinical guidelines should be undertaken whenever possible.
So in this audit, we assess the quality and the time frame of how medication is managed in patient, and particularly how polypharmacy is managed. So we saw the number of medication that was prescribed on admission, whether the structure of medication review and reconciliation was performed during admission, how much was of prescribed medication was actually prescribed or changes were recommended and implemented during admission. Additionally, the audit also evaluated the clarity and the completeness of documentation related to any modification of any medications in prescribing. Methodology of this audit was in total, we included 30 patients who met the inclusion criteria. All eligible patients were above the age of 65 or older, and they were all admitted for less than 1 month in the hospital. Data was collected from electronic records and the GP records of pre-admission medication. For each patient, the following information was extracted: the age of the patient, the sex, the clinical frailty score, pre-admission medication list, and the nature of deprescribing changes that was made during admission. While our audit looked on deprescribing changes in all patients, our focus was on patients with clinical frailty score of 7. So these patients are fully dependent, have greater frailty, and the main outcome was measured was whether prescribing recommendations were carried out by doctor or the senior pharmacist on the ward.
The standards that we use to assess medication appropriateness were based on the stop-start criteria, which is linked below. These are evidence-based tools designed to optimize prescribing in older adults by identifying both inappropriate medications to stop or potential prescribing omissions to start. As of the latest version, there are 80 stop criteria and 34 start criteria, which are all grouped by physiological systems and are intended for use by professionals when reviewing medications in older adults, especially those with multimorbidity or polypharmacy. And the stop criteria, they help clinicians recognize the drugs that can pose more risks than benefits in these older patients. And together, these tools, they support safer and more effective prescribing practices, particularly in the context of polypharmacy.
So we have made a graph to make it easier for everyone who's viewing today. So on one of the axes, you can see the number of patients, and the other axis, you can see the number of medications. So among 30 patients, 12 patients were prescribed among 6 to 10 medications. And as you can see, there were 2 patients with their more than 20 medications, especially in older demographics. These are a lot of medications. These findings also highlighted the significant prevalence of polypharmacies in populations, and we needed to emphasize that medication review and consideration of deprescribing when appropriate.
We also looked at who performed the initial medication review, and you can see in the pie chart, the majority of cases were actually reviewed first by the pharmacist, whereas doctors conducted the initial review for patients. Typically in the hospital we work in, the doctors will clock the patients in and they will, add the medications their own pre-admission. But in our experience, it's the pharmacists who do the first thorough medication review, looking at what could be, stopped or held for now. Essentially, these findings, they highlight the essential role that pharmacists play in the initial thorough assessment of medications. However, they do show that there's increased scope for more involvement of doctors in this process as well. I think given the clinical oversight familiarity the doctor has with the patient's overall care plan and condition, there could be a more active role played in the initial medication reconciliation to support these safe deprescribing practices and optimize therapeutic outcomes of a patient.
There's another graph where you can see where deprescribing changes and the meds were recommended. So in majority of cases, especially 19 out of 30 cases, about 63% where a recommendation of medication adjustment was carried out, while 11 cases among 30 patients, that is about 37%, were not carried out. This suggests that significant proportion of patients had the opportunity for medication optimization during this audit period.
The final graph was quite an important one. It illustrated the number of medications on admission versus the number of medications stopped during admission, particularly for patients with a clinical frailty score of 7 or greater, which we mentioned before. These patients are fully dependent on others for their care. They're severely frail, so there is scope to maybe stop medications. We can see that on admission, there was multiple polypharmacy, prescribed numbers ranging between 7 and 20, and we can see patient 6, that's the highest number at 20 medications. However, in contrast, deprescribing only occurred in a few cases, so 4 cases out of 10, and even then, only 1 or 2 medications were stopped. So it does show that there is a significant gap in deprescribing and a need for more proactive medication reviews, structured deprescribing practices during these hospital stays to try and reduce the risks associated with inappropriate polypharmacy.
The discussion about this audit is this audit highlights the greater focus of deprescribing in patients with clinical frailty scores of 7 or greater, because as we said in the first slide, these people are fully dependent. So the prevalence of polypharmacy is significant and is likely to be a remaining problem. The availability is our system uses an electronic record that we can use to our potential, but it's still not being done in this group of patients.
So thinking sort of why this could happen, I think there is sort of a known phenomenon of clinical inertia, difficulty of thoroughly evaluating benefits and risks of medications. But sort of other potential reasons for limited deprescribing can include things like lack of knowledge of these available resources. They may be unaware of structured tools like the stop-start guidance that support safe and evidence-based deprescribing. Lack of time is probably quite a big one. I think geriatric patients can present with multiple comorbidities. It can have complex care needs, and medication reviews can be time-consuming, and specifically in busy clinical environments, it can lead to prioritization of acute medical issues over proactive deprescribing. Reluctance from patients is also quite a prevalent one. I think patients who've been on long-term medications, they can feel anxious, uncertain about stopping them, and addressing these issues require time and their communication reassurance as well. And lastly, there may not be enough awareness about limited benefit of drugs in advanced frailty. Sometimes long-term benefits of some medication, like bisphosphonates in bed-bound individuals, they're unlikely to sustain fractures. Statins in primary prevention, they're often minimal. Sometimes the knowledge is just not known, and sometimes prescribers can continue these medications by default rather than assessing the appropriateness in light of life expectancy and functional goals as well. So these are just a few reasons that we could think of for these limited deprescribing changes as well.
So the way we can use the recommendations are integrate medication review in admission protocol, provide education and training to doctors so that we can offer a workshop for doctors how to deprescribe, how to use the tools that is available to us, like the start criteria, and why it is very important that these medications get reviewed for older patients. Promote more MDT meetings. So this can be a multidisciplinary practice all over in any hospitals between the nurses, the doctors, and the pharmacist can have a group meeting and see the relevance of particular drugs.
Other sort of ways that we could think of recommending is allowing protected time during ward rounds or admissions, specifically for medication reviews, just to ensure it's not overlooked due to time pressures. Integrating patient preferences and having patient-centered discussions is very important. Consider their preferences, consider their goals as well. And of course, regular auditing and feedback to review these practices, provide constructive feedback, and look for areas of improvement are very important as well.
So the conclusion for this audit is that there is a strong clinical, pharmacological, and financial reasoning for deprescribing in patients in advanced frailty. So there should be, as we said before, there should be a multidisciplinary approach towards this kind of problems to recognize and use the opportunities for deprescribing in this particular cohort. It's by implementing recommendation, healthcare professions will be better to address these challenges in aging population and provide high quality treatment for older patients that has complex needs and social care needs.
So yes, that concludes our presentation today. Here are the references that we use, the stop-start criteria, the NICE guidelines as well. It's looking at other studies as well. So thank you very much for listening.
Thank you.